In an earlier presentation, I talked about the use of adhesive dentistry techniques to reattach fractured tooth segments. Today, we will discuss using those same techniques for splinting of teeth that have been displaced from the tooth socket. When an object strikes a tooth, energy is transferred to the tooth, often resulting in fracture of the crown or root. Energy can also be transferred to the supporting tissues, specifically damaging the periodontal ligament, the cementum of the tooth, and often the alveolar bone. Application of a splint allows the torn or stretched periodontal ligaments to properly repair. Avulsion refers to a tooth that is completely removed from the socket. Luxation injuries are where the tooth is displaced but not completely lost from the socket. This can be in any direction, laterally, buccally, or lingually, as well as intruded or extruded. Finally, subluxation injuries refer to a tooth that is loose but has remained in normal position. The illustration at the right is from the Dental Trauma Guide, a collaboration between the International Association of Dental Traumatology and Copenhagen University Hospital, and I have received permission for its use. It depicts an extrusion injury where the tooth is displaced downward out of the socket. Rather than a comprehensive look at treating these types of injuries, today we will focus on the techniques used in applying a splint to the teeth that have sustained this injury. Studies have shown that teeth that have sustained these injuries can often heal without splinting. However, there are good reasons to apply a splint. Teeth that have been avulsed or have extensive mobility should be splinted to minimize the possibility of additional injury to the cementum and periodontal ligament. Also, even with minimal mobility, patients will often find that splinting relieves the discomfort associated with the traumatized tooth. Another consideration, from a very practical standpoint, is to eliminate the chances that a patient might displace the tooth again and possibly swallow or aspirate it. The American Academy of Pediatric Dentistry has outlined these 8 features that are important in a good splint. Of particular importance is that the splint be passive and allow for natural tooth movement. To be passive, the splinting material must be adapted to the arch form of the teeth to be splinted. If it is not, it will cause pressure on the teeth similar to orthodontic forces. In addition to possibly moving the teeth, an improperly applied splint can cause additional injury to the traumatized tooth. A splint also needs to be non-rigid to allow for slight movement of the teeth. Although most splints are not left in place for more than 7 days, ankylosis of the splinted teeth can occur if the ligaments are not allowed to stretch and compress normally. This is an example of a splint placed on a typodont. In a situation demonstrated here, one of the central incisors would have been injured. I will review specific techniques in the live presentation, but you can see here that the wire splint is held in place by composite resin that has been bonded to the facial surfaces of the teeth. The process would be to isolate the area from moisture as you normally would do for adhesive procedures. That includes preventing any blood from the gingival sulcus or other injuries such as a lacerated lip or cheek from contaminating the area. The wire that is used must be adapted to the contour of the teeth so that it fits passively across the facial surfaces. An alternative is a dead soft wire or other material that has no resiliency, so that it will remain positioned without a tendency to return to its original shape. Once you have isolated the area, acid etch would be applied to small areas on the facial surfaces. This is rinsed and dried before applying bonding agent. Once this area is prepared, the wire is carefully placed over the bonded areas and luted to the tooth with a bead of composite resin. Let's review some key points regarding splinting. Splinting is not always required for repair of damaged tissues, but should be used when it is required to prevent further injury to the tooth, to secure the tooth in the socket, and when needed for patient comfort. Since we are using adhesive dentistry, the field must be well isolated. Splints are generally left in place for 7 days, unless there is significant mobility or if the patient discomfort calls for leaving the splint in place longer. It is crucial that patients have excellent oral hygiene in the area of the splint, and the use of chlorhexidine will aid in the healing of soft tissue injuries. The American Academy of Pediatric Dentistry also recommends that patients with splints consume a soft diet, avoid biting on splinted teeth, and call immediately if the splint breaks or loosens. In the live presentation, we will review splinting in more detail and take a closer look at some of the materials that we can use.